Now we'll talk about the thorax and lungs. Because we all depend on the respiratory system to survive, its assessment is a critical part of the physical examination. To help you perform those assessments as thoroughly as possible, this program will show you how to inspect, palpate and percuss the thorax, and auscultate the lung sounds. Throughout this examination, you'll see normal findings. But keep in mind that in your practice, you may see the same findings, normal variations, or abnormal findings.
Before examining the thorax and lungs, consider their anatomy. For example, recall that the diaphragm separates the thoracic cage from the abdomen, and that the thoracic cage is defined by the sternum, 12 pairs of ribs, and 12 thoracic vertebrae. To localize your findings, remember the surface landmarks of the anterior thorax: the suprasternal notch, sternum, manubriosternal angle, or angle of Louis, which is continuous with the second rib, costal margins, and costal angle. Also count down the ribs, beginning at the sternal angle. Palpate the second rib and slide down to the second intercostal space. Number each intercostal space by the rib above it. Count down the middle of the hemithorax to the 10th rib. On the posterior thorax, use different surface landmarks. With the person's head flexed, feel for the most prominent bony spur, called the vertebra prominens, or the spinous process of C7. Count down the spinous processes. At the 7th or 8th rib, you'll reach the inferior border of the scapula. Finally, you'll reach T12 and the 12th rib. To further pinpoint your findings, use reference lines. On the anterior thorax, note the mid-sternal line, mid-clavicular lines, and anterior axillary lines. On the posterior thorax, refer to the vertebral or mid-spinal line and the scapular lines. And on the lateral thorax, imagine the mid-axillary line, anterior axillary line, and posterior axillary line. Consider the lungs and their structures. Anteriorly, the apices rise 3 to 4 centimeters above the clavicles. In the right lung, the horizontal fissure runs from the 5th rib in the mid-axillary line to the 4th rib at the right sternal border. The oblique fissure runs from the 5th rib in the mid-axillary line to the 6th rib in the mid-clavicular line. They divide the lung into the upper, middle, and lower lobes. In the left lung, the oblique fissure separates the upper lobe and lower lobe. Posteriorly, the apices reach C7. The oblique fissures divide both lungs into the upper lobes, which run from T1 to T3 or T4, and the lower lobes, which run down to T10 on expiration and T12 on inspiration. Note that the posterior chest is almost all lower lobes. On the right lateral thorax, the upper lobe extends from the axilla to the horizontal fissure. The middle lobe goes from that fissure to the 6th rib at the mid-clavicular line, and the lower lobe runs from the 5th rib to the 8th rib in the mid-axillary line. On the left lateral thorax, the upper lobe extends from the axilla to the 5th rib at the mid-axillary line, and the lower lobe continues down to the 8th rib in the mid-axillary line. Within the thorax, the trachea extends from the cricoid cartilage to the sternal angle, where it bifurcates into the right and left main bronchi. The bronchi lead to the lungs, which are surrounded by the parietal and visceral pleura, and contain millions of alveoli that cluster like grapes around each alveolar duct.
Take a look at your chest now.
When inspecting the posterior thorax, first notice the shape and configuration of the chest wall. The anteroposterior diameter should be less than the transverse diameter. The spinous processes should be aligned, and the thorax should be symmetrical with no deformities. Be aware that the normal size of the thoracic cavity varies with a person's culture. Whites tend to have the largest chest volumes, followed by blacks, Asians, and Native Americans. Next, observe the position the person takes to breathe. It should be relaxed and support his weight, with his arms resting at his sides or in his lap. Then assess his skin color and condition. There should be no cyanosis, pallor, abnormal pigmentation, or lesions.
Okay, now I'm going to place my hands on your back and have you breathe normally for me.
Begin palpating the posterior thorax by confirming symmetrical chest expansion. Place your hands on the posterolateral chest wall, with your thumbs at T9 or T10. Slide your hands toward each other to pinch up a small fold of skin.
Take a deep breath for me.
Ask the person to take a deep breath. As he inhales, your thumbs should move apart symmetrically. Next, palpate for tactile fremitus, using the ball of your hand while the person repeats a resonant phrase, such as 99 or blue moon. Following a consistent pattern, palpate systematically, beginning over the lung apices. Move from one side to the other and down, avoiding the scapula.
99.
Vibrations should feel the same in corresponding areas on each side.
99.
However, they may feel stronger on the right side between the scapula,
99.
because that side is closer to the tracheal
Feel
bifurcation.
various places on your back. I want you to tell me if you feel any pain or tenderness.
Then gently palpate the chest wall. The skin should feel warm and dry, and you should detect no tenderness, masses, or lesions. To percuss the posterior thorax, follow this pattern systematically. Start at the apices and percuss across the tops of both shoulders. Then percuss in the interspaces, moving from side to side and down. In each area, note the intensity, pitch, and duration of the percussion notes. They should match side to side. Over the lungs, percussion should produce resonance. Over the viscera, percussion should cause dullness. Note any areas of abnormal dullness or hyperresonance over the lungs.
Okay, Mr. Chang, I'm just going to need to put a few pen marks on your back. Is that okay?
Now use percussion to determine diaphragmatic excursion.
When I tell you, I want you to exhale and hold it.
To do this, ask the person to exhale and hold it.
Okay, exhale and hold it.
Then quickly percuss down the scapular line until the sound changes from resonance to dullness. Mark this spot with a pen. Next, ask the person to take a deep breath and hold it.
Now take a deep breath and hold it. Good.
Then percuss down from your first mark. At the point where the sound changes from resonance to dullness, make another mark.
Okay, now we're going to do the same thing to the other side. So I want you to take a deep breath, exhale, and hold it.
Repeat this procedure on the opposite side.
Good. Okay, now inhale and hold it.
The diaphragm may be 1 to 2 centimeters higher on the right side because of the liver. Then measure the difference between the two marks. Diaphragmatic excursion should be equal bilaterally and normally ranges from 3 to 5 centimeters or up to 8 centimeters in well-conditioned athletes.
Okay, Mr. Chang, I'm going to listen to your lungs now.
To prepare to auscultate the posterior thorax, ask the person to lean forward slightly, let his arms rest in his lap, and breathe through his mouth a little deeper than usual. Clean the diaphragm of the stethoscope with an alcohol wipe. Then follow a consistent pattern for auscultation. Holding the diaphragm of the stethoscope firmly on the chest wall, listen from the apices at C7 to the bases, comparing breath sounds from side to side. Listen to at least one full respiration in each location. Also, auscultate laterally from the axilla down to the 7th or 8th rib. Because deep mouth breathing may tire an older person, allow brief rest periods or quiet breathing during auscultation. And if she feels faint, have her hold her breath for a few seconds. As you listen, ask yourself, what should I expect to be hearing over this spot? And what am I hearing? On the posterior thorax, you should hear bronchovesicular sounds over the major bronchi from T1 to T4. These sounds are moderate in pitch and amplitude, last equally long on inspiration and expiration, and sound like this. Over peripheral lung fields, from the clavicles to T9, you should hear vesicular sounds. They are soft, low-pitched rustling sounds that are longer on inspiration than expiration. They sound like this. You should not hear any adventitious sounds, such as crackles or wheezes. Fine crackles are discontinuous, high-pitched, short crackling sounds on inspiration. Coarse crackles are loud, low-pitched bubbling sounds that start in early inspiration. High-pitched wheezes are musical squeaking sounds, mostly on expiration. Low-pitched wheezes are musical snoring sounds, mostly on expiration. In an older person, you may hear adventitious sounds called atelectatic crackles. These short popping crackling sounds are like fine crackles, but do not last beyond a few breaths and occur only in the periphery.
Now I'm going to have you say 99 every time my stethoscope touches your back.
If you suspect a lung problem, auscultate for voice sounds as the person repeats certain words or sounds. First,
99.
ask him to say 99
99.
as you listen with the diaphragm of the
99.
stethoscope. His voice should
99.
sound soft, muffled, and indistinct.
99.
If you can
99.
auscultate the word clearly, bronchophony is present.
99. 99.
Next, ask the person to make a long
Now I'm going to
E
have
sound.
you say E every time you feel my
You should
stethoscope.
hear the E sound through your stethoscope.
E,
But if the E sounds like A with a bleating quality,
E,
you have detected egophony.
E, E.
Good. Now I want you to whisper 1, 2, 3 every time my stethoscope touches your back.
Then have the person whisper a phrase like 1, 2, 3. The words should sound very faint and muffled.
1, 2,
If they sound louder and clear, you have elicited whispered pectoriloquy.
1, 2, 3. 1, 2, 3.
To assess the anterior thorax, begin as you did on the posterior thorax, noting the shape and configuration of the chest wall. The ribs should slope down and have symmetrical interspaces. The costal angle should be 90 degrees or less. Note
Okay,
the
Mr.
person's
Karen, we're
facial
halfway through the
expression,
examination.
which
Are you
should be
comfortable?
relaxed,
Yeah, I'm doing okay.
and his level of
Not too hot, not too
consciousness,
cold?
which should be alert.
Okay, good. Let me just take a look at your fingernails here.
Also observe the skin color and condition. You should see no cyanosis or pallor on the lips or nail beds, and no lesions on the thorax. If the person is darkly pigmented and cyanosis is difficult to detect, assess for other signs of hypoxemia, such as decreased level of consciousness and respiratory distress. Assess the person's respirations, which should be effortless and noiseless. cause symmetrical chest expansion and occur regularly at 10 to 20 breaths per minute. Palpate for symmetrical chest expansion by placing your hands on the anterolateral wall with your thumbs along the costal margins, pointing toward the xiphoid process. As the person takes a deep breath, watch your thumbs move. Normally, they move symmetrically and smoothly with the chest. Now, palpate for tactile fremitus as the person says 99 or blue moon. For a woman, avoid palpating and percussing over breast tissue because it dampens the sound. Following a consistent pattern, palpate systematically. Begin over the lung apices in the supraclavicular areas and compare from side to side as you move down the chest.
99,
Vibrations
99,
should feel the same in corresponding areas on each side.
99, 99.
Now I'm just going to press on your chest a little bit. I want you to tell me if there's any pain or tenderness.
Next, palpate the anterior chest wall. You should detect no lumps or tenderness and should find normal skin mobility, turgor, temperature, and moisture. To percuss the anterior thorax, follow this pattern. Begin with the apices in the supraclavicular area. Then percuss from side to side in the interspaces, moving down the chest. Over the lungs, percussion should produce resonance. Over the liver and heart, percussion produces dullness. Over the stomach, it causes tympany.
I'm going to listen to your lungs now.
Using this pattern, auscultate the anterior thorax. Remember to use the diaphragm of the stethoscope. Listen for one full respiration in each location, and compare from side to side. For an infant or toddler, be sure to auscultate with the diaphragm of a pediatric stethoscope. Otherwise, the sounds may be distorted. On the anterior thorax, you should hear bronchial or tracheal sounds over the trachea and larynx. These sounds are high-pitched and very loud, have a harsh tubular quality, and sound like this. You should hear bronchovesicular sounds around the upper sternum in the first and second intercostal spaces. You should hear vesicular sounds over peripheral lung fields from above the clavicles to the seventh intercostal space.
Now I want to hear you say 99.
If you detect abnormal breath sounds, assess the voice sounds on the anterior thorax as you did on the posterior thorax.
99, 99.
When you've completed your examination of the thorax and lungs, discuss your findings with the person
Earlier you said you wanted to talk about smoking.
Yeah,
and answer any questions he may have.
I don't feel good about it. I know it's bad for me, and they ban it at work and everywhere that I like to go. And I really think I should quit.
And to keep him on the road to good health, teach him about health promotion and self-care topics related to your findings.